Today we are going to review a GI effects report. This report is from a 62-year-old female with diarrhea that had an acute onset 2 months ago, and now it waxes and wanes. She also experiences intermittent abdominal cramping. She had a normal screening colonoscopy 2 years ago. At the top of the front page, we see three main areas of GI function arranged in the DIG format to represent digestion, inflammation, and the gut microbiome. The color-coded circles at the top of the page correspond with the circles on each pillar listed in the middle of the page. The key shows us that red circles indicate a high need for support, and when prioritizing treatment, these areas should be addressed first. In this case, we see that the inflammation, infection, and metabolic imbalance pillars are red with scores of 10, 9, and 7, and that is where we would want to focus with this patient. You can see the biomarkers listed under those scores that are part of the algorithm that triggers those scores. In the inflammation pillar, we see that both calprotectin and occult blood have an up triangle next to it, indicating they are elevated. In the infection pillar, we see that there is a pathogenic bacteria and a potentially pathogenic bacteria present. Underneath the biomarkers section, we see a list of possible therapeutic support options. Clinicians can use this as a general reference to guide treatment. The gray circle for maldigestion indicates an optional need for support. We will look at those digestion markers when we get to the biomarkers pages to determine if any support is needed. However, we have a pretty good idea that addressing the extreme inflammation and infection should be a priority. Often when these areas are addressed therapeutically, you may see the biomarkers in other categories such as dysbiosis or metabolic imbalance normalize because you are balancing the whole environment. The next 2 pages of the report include the commensal microbiome analysis, which is a summary of findings from the 24 commensal bacteria that we measure on page 5 that you can see pictured to the right of the screen. At the top, we see that this patient's commensal abundance is slightly higher as compared to a healthy cohort. It is not extremely high and may not necessarily warrant an intervention. Higher abundance may be seen with bacterial overgrowth or when supplementing with pre- and probiotics. A lower abundance is often seen after a course of antimicrobials or diets low in prebiotics. The dysbiosis patterns includes an inflammation-associated dysbiosis score and methane dysbiosis score, which are derived from proprietary algorithms that take into account the commensal bacteria patterns seen in conjunction with other biomarkers. Each zone has a different meaning clinically, and therefore support options may change. In this case, both the IAD score and methane dysbiosis score were low, and we see that this patient's result is in zone 1. The commentary to the right on the report says that zone 1 does not align with profiles associated with intestinal inflammation or immunosuppression. Clinically, if a patient in this zone has elevated inflammatory biomarkers, which this patient does, then other causes of intestinal inflammation other than dysbiosis need to be excluded. Other causes include infectious pathogens, celiac disease, food allergies and sensitivities, or more serious pathologies. We do know that this patient has elevated calprotectin and an infectious pathogen, so this points back to placing priority on addressing the pathogen. The Commensal Balance graphic shows that this patient's result is falling within the yellow shaded region. This compares the patient's commensal findings to a pattern seen in a healthy cohort. Green would be considered optimal, so we might consider strategies that would optimize the microbiome, such as pre- and probiotics. Finally, at the bottom of the page, we see the relative commensal abundance. There are 7 major phyla that can be seen when assessing the microbiome, and here we are looking at the relative proportions of each phyla as compared to a healthy cohort. The phyla are quite diverse with regards to the bacteria that make up each phylum, and in some cases may be influenced by certain dietary patterns. In this case, we see that the Bacteroidetes phylum is slightly more abundant as compared to the healthy cohort, and this can be influenced by an animal-based diet depending on which species are elevated. At the top of page 4, we have the digestion and absorption markers. Pancreatic elastase 1 is a proteolytic enzyme that serves as a marker of overall pancreatic exocrine function. The patient's finding is 295, which is in the green, so no impaired pancreatic function. Most people have a finding of greater than 500. Less than 200 is considered pancreatic insufficiency. If PE1 is low, it's important to determine the cause, and pancreatic enzyme replacement can be started. PE1 measurements are not influenced by exogenous enzyme supplementation and only represents endogenous levels. Products of protein breakdown are made by bacterial fermentation of protein. The patient's level is normal at 5.6. When elevated, it may indicate hypochlorhydria, pancreatic insufficiency, bacterial overgrowth, GI irritation, inflammation or bleeding, or increased protein intake. Next, the fecal fat total was low normal. The fecal fat total includes all 4 fats listed. An elevated total fecal fat can identify if a person is not properly digesting and/or absorbing fats. Lower fecal fats may reflect dietary intake. Overall, digestion and absorption are not identified as an issue for this patient, therefore there are no therapeutic recommendations. In the middle of page 4, we have the inflammation and immunology section. Calprotectin is a marker for neutrophil-mediated inflammation. It is FDA cleared to distinguish between irritable bowel syndrome and inflammatory bowel disease. This patient's level is 114, which is close to the red zone of 120. A finding above 120 is considered significant and warrants a referral for colonoscopy. For levels that are 50 to 120, we recommend following up with another calprotectin in 4 to 6 weeks. Besides inflammatory bowel disease, other causes of elevated calprotectin include infection, which we know this patient has, chronic NSAID use, diverticulitis, and colorectal cancer. Eosinophil protein X is a marker for eosinophil-mediated inflammation and can be elevated in association with parasites or IgE-mediated food allergies. This finding is low, which is considered normal. Fecal secretory IgA is secreted from mucosal surfaces. The patient's level is not elevated. When elevated, it may provide information about an immune response to pathogenic organisms or disordered gut barrier function, which has been associated with the development of food allergies and sensitivities. At the bottom of page 4, we have the gut microbiome metabolites section. Commensal gut bacteria anaerobically ferment resistant starch and dietary fiber, including prebiotics, to produce the beneficial short-chain fatty acids butyrate, acetate, and propionate. The patient's total short-chain fatty acid level is low normal, as is their N-butyrate level. Low concentrations suggest either dysbiosis or inadequate substrate for commensal organisms to ferment. While optimal levels have not yet been identified, higher concentrations have been associated with decreased GI disease. N-butyrate is the primary fuel source for colon epithelial cells. There are many ways to support short-chain fatty acids. Probiotics, prebiotics, and fiber can be beneficial for raising levels. Prebiotics can be provided as a supplement, such as inulin, fructooligosaccharides, or FOS, arabinogalactan, or from diet. Plant foods rich in fiber include whole grains, seeds such as ground flax or chia, legumes, and vegetables. The percentage breakdown of the 3 short-chain fatty acids is a percentage of the total short-chain fatty acids. These are made by different bacteria, and when there is an underlying bacterial imbalance, these percentages may also be imbalanced. So you want to address the underlying bacterial imbalance. Next, beta-glucuronidase is an enzyme, as you can tell by the ASE ending. This enzyme is made by anaerobic bacteria. It deconjugates and recirculates substances that were packaged for elimination during the phase 2 glucuronidation process. This patient's finding is low, but we are more concerned when it is elevated. High or low levels may be due to an underlying bacterial imbalance. If there are elevated levels, one consideration would be supplementing with calcium D-glucarate, which can directly inhibit the enzyme. Probiotics are also beneficial for restoring bacterial balance. On page 5, there are 24 commensal bacteria assessed by PCR technology. We have already summarized what the data means with the commensal microbiome analysis on pages 2 and 3. Remember that the patient had borderline commensal balance and relative abundance findings. It is not uncommon to see H's and L's, or highs and lows, on this page, as every patient is going to be unique with regards to their microbial fingerprint. We do have a commensal bacteria chart that you can download from our website that lists each organism and dietary or lifestyle associations when the finding is high or low. A few things to point out on this page are the levels of lactobacillus and bifidobacterium, which are found in probiotic supplements and fermented foods. If we look about halfway down the page under the Firmicutes phylum, we see low normal lactobacillus levels. Below that, in the Actinobacteria phylum, we see that the bifidobacterium levels are also at the lower end. As mentioned, a probiotic may be helpful here. Lastly, the Firmicutes Bacteroidetes ratio at the bottom of the page was low. This ratio represents the two largest phyla that make up the gut microbiome, and the relationship of the two results in an imbalanced ratio that has been associated with conditions including obesity. For any microbiome imbalances, including this FB ratio, it is important to address all the other findings on the report, as well as consider pre- and probiotics and lifestyle or dietary factors that may contribute to imbalances. Here we have the commensal bacteria chart that shows the individual bacteria and associations, and I'm showing Akkermansia here. This patient had low Akkermansia, which is important for gut membrane integrity. The chart shows that higher Akkermansia levels are associated with resveratrol, pomegranate extract, inulin, and even physical activity, and lower levels are associated with a low FODMAP diet. Page 6 of the report lists all the organisms that were grown out in culture. We have 3 commensal bacteria at the top: Lactobacillus, E. coli, and Bifidobacterium. We see NG, no growth, for Lactobacillus and E. coli, and 1+ for Bifidobacterium. Bacterial culture complements the PCR assessment to provide a more complete survey of a patient's gut microbiota. The thing to note here is that we see Lactobacillus and Bifidobacterium low in both PCR and culture, again supporting the need for probiotics. It is not uncommon for patients to have a few additional bacteria. If the diamond falls within the green zone, it is considered non-pathogenic. If the diamond is within the yellow zone, the organism is considered a potential pathogen, and we provide sensitivities at the end of the report. These are considered potential pathogens, meaning they may be problematic in some patients and others may be asymptomatic. Red indicates a true pathogen. So for this patient, there was 1 pathogen and 1 potentially pathogenic bacteria present. Here's a section on Aeromonas from our pathogenic bacteria and yeast chart, which can be found on our website. Aeromonas can be associated with bloody diarrhea. Citrobacter may be asymptomatic or associated with diarrhea. And at the bottom we see there is a little bit of yeast in the mycology section, but at a 1+, this is not significant. Here we have the sensitivities for the pathogen Aeromonas hydrophila and potential pathogen Citrobacter. Aeromonas was sensitive or susceptible to gentamicin, ciprofloxacin, and trimethoprim sulfa in the S column. Citrobacter was susceptible to cipro, tetracycline, and trimethoprim sulfa, and anything in the R column would not work. Under natural agents, if the gray shaded bar reaches the 50% or halfway mark, it's considered a good agent to use. So all 4 natural agents, berberine, oregano, plant tannins, and uva ursi, would all be good agents to use against both of these organisms. The bottom of the sensitivities page lists a key describing the categories of susceptibility and resistance. On page 7, we have the parasitology section. No ova or parasites were seen under the microscope. On page 8, all 6 PCR parasite tests are negative. When a test comes back positive for blastocystis, we run a reflex for subtyping the blastocystis. This patient did not have blastocystis, so the results for subtyping are NA, non-applicable. At the bottom of the page, we see that fecal occult blood was positive. We think about fecal occult blood screening for colorectal cancer, but it can be elevated with inflammatory bowel disease, and we know she has a bacteria that can be associated with bloody stools. Consistency and color are reported by the patient at the time of collection, and those were normal. Additionally, on this page, some practitioners may add on pathogenic bacteria if clinically indicated, and those are assessed via FDA-cleared enzyme immunoassay. These add-on bacteria include H. pylori, Campylobacter, Shigatoxin E. coli, and Clostridium difficile. These were not added on to this report because the patient already had these tests run 2 months ago at their local lab at the acute onset of her diarrhea. That lab ran an acute diarrhea panel, which did not include a culture, and probably why the Aeromonas wasn't found until now. Lactoferrin is another add-on marker of neutrophil-mediated inflammation, but was not added on here. We do already have the Calprotectin, which is a marker for neutrophil-mediated inflammation, and we did see that that was elevated with this patient. The clinical association charts were derived from our data analysis that compared a healthy cohort to various clinical condition cohorts listed across the top of the page. The blue arrows show if those biomarkers were higher or lower compared to the healthy cohort. If a patient has one of these diagnoses, their results can be compared to other patients who have that same diagnosis. This patient does not have any of these diagnoses. Now we can come back to the front page and summarize the recommendations for this patient. The priority would be to address the infection. Some clinicians may choose antibiotics, while others may use antimicrobial herbal therapy. With antimicrobials that may disturb the microbiome and create more of a dysbiosis, probiotics and prebiotics may also be considered. The inflammation in blood may be due to the infection, so she should retest in 4 to 6 weeks to see that it's hopefully resolving and that the infection has been eradicated and calprotectin is normalized. In the meantime, some clinicians may support the gut with turmeric or fish oil for its anti-inflammatory properties. One more thing to consider with the inflammation and fecal occult blood: the patient did have a normal screening colonoscopy 2 years ago, and these are performed every 10 years. Depending on the patient and their history, some clinicians may choose colonoscopy if they have concern, and the patient has never had a screening colonoscopy at this age. She's 62. In this case, with the history, it seems likely that it's related to the pathogenic bacteria because of the acute onset, but using clinical judgment here is crucial. Because the metabolite imbalance and dysbiosis sections were in the red and yellow, suggesting high and moderate need for support, Pre and probiotics, fiber, and resistant starches would be good to incorporate. There are several resources listed here that you may find useful for learning more about the GI effects. We have our support guide, Pathogenic Bacteria and Yeast chart, Commensal Balance chart, and Parasitic Organisms chart, LearnGDX educational modules, live GDX monthly webinars, the Lab Report podcast, and don't hesitate to schedule a medical education phone consultation with one of our medical education team members. We're here to help you with test interpretation or choosing the right test for your patient. Thank you for visiting LearnGDX.